Tonight, I have the pleasure of introducing one of my very favorite speakers of all times, Dr. Tanya Dorff. If you could hold your questions during the presentation, we will give you a chance to do questions after Dr. Dorff has finished. A little background on Dr. Dorff. She received her Bachelor of Science in Biology with summa cum laude honors at the University of Houston, Houston College, Houston, Texas in 1995. She then went on to receive her MD with honors from the AOA Honor Society at UCLA School of Medicine in 2000. After that, she completed her internship and residency in internal medicine at Mount Sinai Hospital in New York. She returned to LA to do her fellowship in hematology and medical oncology at LAC-USC Medical Center in Los Angeles, which she completed in 2005. In 2006, she was at LAC-USC Medical Center as a chief fellow in medical oncology. 2006 to 2008, Los Angeles Clinic and Research Institute in Los Angeles as a staff physician in genitourinary oncology. I practiced that 3 times today, I still didn't get it right. From 2008 to the present, she's been in the University of Southern California Keck School of Medicine as Assistant Professor of Clinical Medicine, Division of Medical Oncology. Following a residency at Mount Sinai Hospital in New York City, Dr. Dorff came to LAC-USC Medical Center on a hematology and medical oncology fellowship. She currently teaches the Division of Cancer Medicine and Blood Diseases at the Keck School of Medicine of USC. In addition to being a devoted clinician and researcher, Dr. Dorff has authored numerous published articles and serves as a reviewer for many journals, including Cancer and the Current Cancer Drug Targets. She has lectured on the topic of both prostate cancer in both English and in Spanish across California, and has been either the principal or co-investigator on a dozen clinical trials. I can't list all her credited publications, but I can give you an idea of how prolific her studies are. That's just a minor list. It's with great pleasure that the Prostate Forum of Orange County presents Dr. Tanya Dorff.
Well, thank you. That was probably the best introduction I've ever gotten. So it's my pleasure to be with you today, and I'm going to be talking about chemotherapy, which I think is a topic that most men, and let's face it, most people don't really want to talk about, but I think it's really important, and I'm going to show you some of the new data that were presented at our annual meeting in Chicago last June that's kind of turning our whole paradigm about how we use chemotherapy and when on its head. So can people hear me okay, or do I need to pipe up even louder? No? All right.
Mari, can you hear back there? Yeah. Okay.
So the fact that chemotherapy works for prostate cancer is not actually a surprise. It's not actually new. These 2 studies were published back in 2004 using what we now call the standard of care for men with castrate-resistant prostate cancer. And that is docetaxel, or the brand name is Taxotere. So probably you mostly hear doctors refer to it as Taxotere. So the paradigm was that hormone therapy, which works really, really well, is going to be our first line of attack, and then once that fails, then we're going to bring in the chemotherapy. So these 2 studies compared Taxotere to an older form of chemotherapy, which was mitoxantrone, and found a survival benefit. Small, but real. You can see here the relative increase in 2-year survival of 27%. So this was a significant advance, and again, published in 2004. Despite this, I still hear from patients who come to me for a second opinion, or to look at some clinical trials that they've been told chemotherapy doesn't work for prostate cancer. And I think it's helpful to look not just at the graphs, but to look at individual experiences, because this talks about populations and not what's going to happen for you. So chemo doesn't work for everyone, just like hormone therapy doesn't work for everyone, although hormone therapy really works for nearly everyone with prostate cancer, at least for a period of time. But chemotherapy, when it works, can work fantastically. So I had a patient, for example, who started out with a PSA of 2,000. PSA was rapidly going up, had gone from 10 to 100 to 500. I mean, it was rapidly rising. He actually felt well. A lot of people worry about pain with prostate cancer, and despite having bone metastases, this guy was not in pain. So you don't necessarily have to have pain to have aggressive prostate cancer or prostate cancer that needs chemotherapy. After one dose of Taxotere, his PSA dropped from 2,000 to 200. Okay, and I think he was just having an explosion of dying cancer cells inside of him. His electrolytes got all out of whack. But we powered through, and after a few rounds, his PSA was back down in the single-digit range. And then we went on to use other treatments. So that's one of my sort of take-home messages. Some people view chemotherapy as the end, as the last thing I'll ever need for my prostate cancer, as one step before the final exit. But it's not. It's a tool. So we have a lot of tools for prostate cancer. We have hormone therapy, we have immune therapy, we have radiation therapy, and we have chemotherapy, and we use them at different times. And we use them usually for a period, and then we'll go to something else, and then we might come back to something else. So I've had some patients, for instance, who have gone through Taxotere. We do, let's say, 6 or 8 or 10 doses. Then we go on to do some other things for a while, and then 3 or 4 years later, we might bring back the Taxotere when we feel like we've come to a point that we need it. So recently, we've had the approval of some new hormone therapy drugs, which has been fantastic. Honestly, I'm so glad to have these drugs. I see them helping my patients every day. And they are enzalutamide and abiraterone. So these drugs were first tested in men who had received Taxotere, because Taxotere was what we had. When hormone therapy stopped working, that was what you went to. And they showed that they could prolong survival compared to placebo. Wonderful. But who wants to use chemo when you could use a pill that's a hormone therapy and really well tolerated? So they did the studies in men who had not yet had Taxotere, and they also compared them to placebo, which is kind of interesting because we have an active comparator. No one went head-to-head against chemo. That being said, those trials, the PREVAIL trial for enzalutamide and the Cougar 302 trial for abiraterone, and I guess I should give you their more common names, so they're Xtandi and Zytiga. That may sound more familiar. So these trials showed a delay in the time to cancer progression, and the PREVAIL trial, which is the Xtandi or enzalutamide trial, also showed a survival advantage, which was pretty remarkable. Many of us didn't expect them to be able to show that, given that once you had been on these drugs, on these trials, you could then go ahead and get your Provenge, your Taxotere, anything else. And some people started getting even Zytiga from the PREVAIL trial because we had more and more treatments available. And if you think about it, when you're intervening early, when there are multiple life-prolonging therapies beyond, to show a survival benefit is a pretty significant thing. So these trials were very groundbreaking, and one of the pieces of evidence that people like to talk about from PREVAIL is this statistic, that the time to chemotherapy use was prolonged by 17 months. Sounds pretty good. So you have prostate cancer, you're on hormone therapy, it's been 2 years, it's been 3 years, however long, now your PSA is rising. Do you want to do chemo or do you want to do a pill that delays your time to chemo by 17 months and prolongs your survival? I think most people are going to choose the pill. And that's fine. That is a completely acceptable paradigm. No one can now say what's the right sequence, how to best use these drugs. That's the kind of stuff we're working on now. In case anyone's interested, I have the citations from these 2 trials listed. The PREVAIL trial hasn't been fully published yet. It was just presented at the plenary of last year's ASCO in Chicago. So last year, also in Chicago, we got this piece of data. So the CHAARTED trial was a study of chemotherapy right from the start. 6 doses with your hormone therapy, with your first dose of hormone therapy, comparing it to just hormone therapy, and then using chemo when your hormone therapy fails, which was the standard paradigm. And no one would have expected it, I don't think. I guess the people who wrote the study expected it. And we certainly put patients on this trial because we believed it was a question that needed to be answered. And this was the result. We saw a huge, huge difference in survival. And many of these patients went on to get drugs like Zytiga and Xtandi. And nearly all, 3/4 of the patients who started out with hormone therapy alone did end up getting chemotherapy. So this wasn't a test of chemo now versus never. This was a test of chemo early versus later, and early showed a tremendous advantage. So this, again, completely a separate way of thinking than where we had been, which was let's get lots of drugs that we can use instead of chemo and push chemo farther out into the future. Here we're saying maybe chemo needs to be something that we start with. So let's take a step back. What was the CHAARTED trial? Well, as I mentioned, it was for men with prostate cancer right at the time that they're starting hormone therapy. So they had to have been on hormone therapy for a very short time to get on. So there was a little wiggle room because often by the time someone like me is seeing a patient, they've already been started on Casodex or Lupron. So we had a little wiggle room, but you couldn't have been on it for more than 30 days. So they really wanted to get the chemo in at the beginning. You were allowed to have had hormone therapy, let's say, with your surgery or your radiation sometime in the past. You were allowed to get medicines to support your bones, things like Zometa. And you were allowed to be pretty much any age, but they did want to look at it by age groups. And you were randomly assigned, if you entered the study, to either hormone therapy with 6 doses of Taxotere, docetaxel. So it's given once every 3 weeks, 6 doses, so that's 18 weeks. Or just to get your regular hormone therapy. So no placebos here. You know what you're assigned to, but you don't get to pick. How does hormone therapy work? If we're going to understand why giving chemotherapy early might be a good idea, I think we need to take a further step back. When we talk about hormone therapy, we're actually talking about depriving the body of testosterone in this case. And Huggins and Hodges won the Nobel Prize for figuring that out, that when you remove testosterone from a prostate cancer cell environment, that they actually die. And the way that this is mediated is through what we call the androgen receptor. So that's this AR. So the testosterone can't do anything to a cancer cell by itself. It needs AR. So it gets converted usually to superpotent testosterone called DHT by 5-alpha reductase, and then binds to the androgen receptor, and this takes it into the nucleus. This is where the action happens. The androgen receptor is the one binding to the DNA and turning on genes that make cancer behave like cancer and turning off genes that would tell the cell to behave like a normal cell. So our hormone therapies target this pathway in different ways. When we give a Lupron or Zoladex or Trelstar injection, we're telling the testicles to not make testosterone, but there is still testosterone in the environment from the adrenal glands, and so we also have drugs that block at the level of the receptor. Drugs like Casodex, which is bicalutamide, or Nalandrone, and some others. So how does hormone therapy fail? If prostate cancer cells are using testosterone to grow, and we either remove testosterone or blockade at the level of the androgen receptor, why does cancer then progress? Why does hormone therapy fail? So there are lots of different mechanisms. And I'll just talk about a few of them. One is that the androgen receptor can mutate. So the place where that Casodex wants to bind is where the testosterone would normally bind. But the androgen receptor can mutate, so the drug can't bind there. It can also mutate, so it just goes to the nucleus. It doesn't need the testosterone to activate it. It just does its own thing. So that's mutations, splice variants. It gets overexpressed. That's probably the first thing that happens, so it can use whatever testosterone is there. And then we learned that the cancer cell is really diabolical. It can actually make its own testosterone. And One of the ways it does that is by a CYP17, which I guess I didn't put on the slide. And so that's where abiraterone or Zytiga works. So that is blocking CYP17, which blocks production of testosterone from the adrenal glands as well as from the actual cancer cells themselves. And there's another drug and several others in development, one that's called TAC-700 that I'll talk about a little bit later. So enzalutamide is over here. It was designed to be a better androgen receptor blocker. So Casodex fails in part because it's just not that good at what it's supposed to do. It binds to androgen receptor and it's supposed to block it, but sometimes it stimulates it, and the androgen receptor can actually mutate to use it to its advantage. So enzalutamide was designed to bind more strongly to prevent the androgen receptor from moving and activating DNA. So if it's still all about the androgen receptor, why wouldn't drugs like Xtandi and Zytiga, why aren't they all we need? Why aren't they curing prostate cancer? Well, cells are incredibly complex, and cancer cells even more so. And so we have multiple pathways. Here's androgen receptor. Here's all these other things, and many, many more that cancer can use to grow. So this is the basis of what we call targeted therapy. So we find, okay, the cancer cell has EGFR. So let's make a drug that blocks EGFR and see if we can shut down the cancer. Or cancer has HER2, let's target that pathway. And the problem is that we can't always predict which of these pathways your cancer is using, or maybe it's using multiple. And so as great as targeted therapy seems, and there are some instances where it's been incredibly successful, it still can't cure cancer. And for coming back to prostate cancer, we can target androgen receptor, we can try to figure out, is your cancer using one of these, and try to target that. But ultimately, what about something that just destroys the cell? Destroys the cell regardless of what pathways are being activated. Well, that's chemotherapy, right? Chemotherapy is a non-discriminate substance that kills cells that are dividing quickly. And in your body, what's dividing quickly? Cancer cells, more so than your normal cells. But the fact that chemo is indiscriminate is why chemotherapy has more side effects, right? As opposed to something that's targeting a more specific change within the cancer, like the things we've been talking about. So Taxotere doesn't do DNA damage per se. So a lot of your older chemotherapy drugs like cisplatin or doxorubicin, cyclophosphamide, those are damaging DNA so that when a cell goes to divide, it can't. The DNA just can't be fixed, the chromosomes can't be made proper, and it can't divide, so it dies. And here's a little basic biology that you guys probably encountered some time ago. Cell division. So in addition to replicating the DNA and making sure there aren't too many errors so that the cell can divide, you need this skeleton that's made up of microtubules. Those are what actually pull the two chromosomes apart so that from one cell you get the two new cells. So everything has to move along these roads of the microtubules. And that's where docetaxel acts. Okay? It is binding to these tubules so that they can't break down. So normally, after you've divided, that skeleton is broken down, and here you've just got these inflexible tubules, and the cell division can't finish up. But cancer is diabolical, right? So why does Taxotere not work? This sounds like a great plan. It's just going to kill cells that are dividing. So why doesn't every cancer patient respond to this? Well, so the cancer can swap out some of the units, the building blocks of their microtubules such that Taxotere can't bind. It can create little pumps that pump the chemo out so that the chemo can't do what it's supposed to do. I mean, it's really fascinating how cancer adapts and this give and take that we have when we're trying to figure out a great new therapy and why then it doesn't always work like we want it to. But generally speaking, this is going to be effective for things that are growing rapidly that are trying to divide. This is going to gum up the works. So how could we use chemotherapy for prostate cancer? Why would we want to use it early rather than when hormone therapy is failing, which is traditionally when we think of cancer cells growing more rapidly? Well, I have this theory of population ecology of prostate cancer. I'm not the only one, but it speaks to the fact that right at the beginning, even before you apply the hormone therapy, you have varying levels of sensitivity to hormone therapy. So right from the start, maybe there are some cells that don't really need testosterone to grow, or where androgen receptor is just not the big story inside that clone of cells that's growing. So if you just apply hormone therapy, sure, the sensitive cells are going to be wiped out, and then what grows? The more resistant cells. And I've put in here a little anecdote of a patient I have where I really feel like there's this clonal evolution happening. So he's got bone mets, PSA is 200. This is very classic prostate cancer. We give hormone therapy. PSA goes close to undetectable. Everything seems fine. PSA is staying low, but all of a sudden a lung nodule pops up for no apparent reason. We biopsy it. It's prostate cancer. So we give chemo, and it goes away. And then PSA starts to rise. The lung nodule's not coming back, but there are new bone mets. So we go with the hormone therapy. So what I think is happening is that we're selecting populations, and there aren't 0 yellow dots to me in the final population. So first we knock out the hormone sensitive and we grow the resistant. Then with chemo we might knock out the resistant, and what's going to grow back, what has the competitive advantage, is probably the sensitive ones again. But if you think that there is resistance right at the beginning, well, that explains why hormone therapy is not a cure. That explains why we kill a whole lot of your prostate cancer, but some remains. There are also other theories and other reasons, right? There's the whole cancer stem cell hypothesis. But if you think about this and the fact that right from the get-go, some cells are going to resist your treatment, then it would make sense to add in something like chemotherapy that could get rid of those resistant cells so that you're really maximally debulking your cancer. I still can't promise we get to 0, right? But we seem to have a big impact based on the CHAARTED data. So, should every single man with prostate cancer that is metastatic get chemotherapy right away? And the answer is no. Okay, so even within that trial, they looked at different subgroups, and really most subgroups benefited. But one thing that came out was that if you had small volume metastatic disease, meaning you had 1 or 2 spots in your pelvic bones or in your spine, you don't seem to benefit that much. It's really men with higher volume of prostate cancer metastases that derive this enormous benefit. We're saying a 17-month benefit. Often you see things like Zytiga or Xtandi that are, a 4-month median prolongation of survival, which underestimates the benefit, to be sure. But gosh, this just blows my mind in comparison. A 17-month prolongation of survival is huge in our world of clinical trials. So high volume was defined as 4 or more bone metastases with 1 outside of the spine or the pelvic bones, what we call the axial skeleton. So if you have 4 bone mets and 1 is in a rib, for instance, or in a humerus arm bone or in a femur, then that counts as high volume. So high volume doesn't have to mean 100 bone metastases, but it can. This was how they defined it, and honestly, this is how I'm trying to advise patients, because if you're not standing to gain much based on the best available data, then why put you through that? Even though, yes, the population as a whole, the whole clinical trial was positive, but with all its limitations, I happen to like this subgroup analysis and the guidance it provides. I do think that when I treat a man with 1 or 2 bone mets, he seems to stay sensitive to hormone therapy longer. I think there's something about how much the cancer has had an opportunity to divide and spread that speaks to the development of de novo resistant cells. And so this kind of makes sense to me in the way I think about the evolution of prostate cancer and why I might need chemotherapy early. So is the question settled? Forever henceforth, will we be saying chemotherapy up front? The answer is no, and there are some very exciting data that I think can help us understand why, despite these amazing results with chemotherapy early, we might not always be doing it in the future. So Mary Ellen Kaplan, who's brilliant and one of my heroes, presented some really, really interesting data. she looked at men before prostatectomy. So traditionally, if you've got localized prostate cancer and you're going to have a prostatectomy, you do not need hormone therapy. It's never been shown to increase your whatever outcome you want to say, lack of PSA recurrence, survival, metastasis. Doesn't seem to do that. The only thing it does is reduce your rate of a positive surgical margin. So really we have abandoned giving hormone therapy around the time of a prostatectomy, generally speaking. There might be specific exceptions. If it happened to you, doesn't mean it was wrong. But generally speaking, we didn't find a huge benefit. And one of the things that we found in experiments where we gave hormone therapy for 3 months or 6 months and then removed the prostate gland, we always still found prostate cancer. And that's different than, let's say, breast cancer, where when you give chemotherapy before a patient has surgery, you will often, or at least a good percentage of the time, find no residual cancer. The chemo is that effective. So hormone therapy is really effective, and yet we couldn't seem to eradicate it from the gland. Well, in her experiment, she took this new drug, abiraterone, Zytiga, which is presumably a more potent, more effective hormone therapy drug, and said, let's repeat the experiment that we did all those years ago with regular hormone therapy. And so she had men take either 12 weeks of just Lupron or 12 weeks of Lupron with Zytiga, and then everyone crossed over and they continued for another 12 weeks. So that's why you have 12 versus 24 weeks, essentially. But what she found in the first 12 weeks is that if within the prostate tissue, because remember these guys had their prostates removed for their definitive curative prostate surgery, within that prostate tissue, she still found a fair amount of DHT, right, the super potent testosterone, in the men who were just on the Lupron type drug compared to the guys on the Zytiga. Remember I was saying that prostate cancer can make its own testosterone, so this really speaks to that. Zytiga is not allowing the cancer to make its own testosterone. And DHEA, which can come from the adrenal glands, but also potentially from the cancer cells themselves. So she found that, and she also found a 10% pathologic complete response rate. So remember I said before we would give hormone therapy 3 months, 6 months. When we removed the prostate gland, we always still found cancer. Well, this time, for 10% of the guys, there was no cancer left. So that's pretty exciting. Maybe our newer hormone therapies are potent enough that when we give them in this early stage, we could actually eradicate every last prostate cancer cell. It's a pretty exciting concept. We can't tell from these data what's going to happen at 5 and 10 years. But this pathologic complete response, this PCR, meaning we found no residual cancer when we removed the organ, has been a benchmark in other cancers that correlates with doing really well long-term, staying cancer-free. So this was very exciting. So maybe we then need to say, okay, instead of chemo up front, maybe what we need is just more effective hormone therapy up front. And that is being done now as we speak. We are enrolling patients on this trial, SWOG S1216. We're taking men with metastatic prostate cancer, and they will either get their regular hormone therapy with bicalutamide, which is Casodex, which is very good. This is tried and true stuff. This is what we use. Or they get the Lupron type therapy with the new drug, the TAC-700, which is similar to Zytiga, abiraterone. It's a CYP17 inhibitor, same mechanism of action. So if this is positive, then we know that upfront chemo and hormones is better than regular hormones, and we know that super hormone therapy or third generation hormone therapy is better than old hormones, but we won't know which approach is actually better. And in my ideal world, we'd actually be coming up with some means of predicting based on your cancer cells which approach might be better for you rather than populations. And we're working on that too. But this might leave us in a setting where up front you might have an option of chemo or the CYP17 inhibitor, and we may have to do further investigation to narrow down what's best. And then there's always the question of combinations. So there are a lot of prostate cancer doctors out there who are saying throw everything at it, all the drugs at once, instead of using them one after the other. So there's a lot of clinical trial work being done to answer these types of questions. All right, so I'm going to talk to you a little bit also about chemotherapy nuts and bolts. because I think a lot of people are really scared of chemotherapy, and Lord knows I would be too if it was something that was going to be happening to me, right? It's a scary word, it's a scary idea. We've all seen people who have gone through chemotherapy, and some of them have really tough times with it. But being an oncologist, I see a lot of people going through chemo, and I actually see a lot of them who don't have such tough times. And among them are my prostate cancer patients, because docetaxel, okay, it's chemo, some people get sick from it, but on average it's a little bit less tough than some of the other chemos. But how can you get through your chemo most successfully? Well, if you're going to have chemotherapy, there are going to be days where you don't feel normal. That's a given. I call those the bad days, and I usually tell my patients, you know, I can't predict how many bad days you'll have, but you will have good days. In that 3 weeks where you get the chemo on day 1, and then you don't come back for 3 weeks, during that time there should be days that you feel pretty normal. So it's not that for 18 weeks you're going to feel terrible. Should not be the case. So you'll have those bad days, and what does that consist of? Well, fatigue, not feeling like eating much. What do I tell people to do? To hydrate. The appetite will come back. Having your spouses around is super helpful, because they'll suggest food in a way that might make you eat more than if you didn't have someone there who cared about you suggesting food, and you might just not eat anything at all. And then, you know, naps, but also a little bit of activity if you can squeeze it in, I think will help get you through those down days. Taste change is a big complaint. So a lot of people with Taxotere can't taste food, and that's why they don't want to eat, because they put it in, they might say, wow, that sounds good or it smells good, they put it in their mouth, it doesn't taste right, who's going to eat it? There's not a real easy solution to that. There are some kind of homespun remedies that we can talk about offline, but there are some foods that will be palatable, and so it's kind of trial and error, finding the things that actually taste good and make you want to eat them. Some people will get diarrhea. It's often something that we can stop. Some people also get constipated. You know, you can take medicines to help you through the chemo. You don't have to just tough it out. Neuropathy is a really tough one, but you don't get that with your first dose of Taxotere or your second dose. It's a cumulative side effect. And neuropathy means numbness or tingling, pins and needles kind of sensation potentially on your hands or feet. And what I see mostly is feet for patients that I'm treating with prostate cancer. Some people will describe it like there are little sandbags on the bottom of your feet. It doesn't sound so bad, but you know, potentially you could fall if you're not able to feel with your feet. It could affect your driving. So there are real life consequences of it. It is mostly reversible, and there are also some medicines that can help if you end up stuck with neuropathy from chemotherapy. And please know, not everyone gets it, okay? It's a minority side effect, especially when we're talking 6 doses, like in the upfront study. And then we watch the blood counts. That's part and parcel of chemo. What else in your body besides cancer grows quickly is your blood, your white blood, your red blood, your platelets. Those have a limited lifespan, so you're constantly making them. And so they take a little bit of hit with chemotherapy. With Taxotere, I don't find too much by the way of low platelets or anemia for most cases. But the white blood cell count definitely can go down, and so your doctor might give you a shot of G-CSF, either Neulasta or Neupogen, to try to avoid you getting sick. It also may help avoid those really low energy days or reduce them, because when your white blood cells are very low, that tends to also be associated with feeling more tired. So above everything else, I tell my patients who are on chemo that you have to call. So for anything, even if you think it's silly, calling your doctor is the best way to get something that's going to help you get better, and don't tough it out until your next appointment. We are working at USC on something to help hopefully also make side effects less from chemotherapy. So I think last time I was here, I don't remember if I talked about my fasting work. But we had done some studies of fasting with other kinds of chemotherapy as a way to reduce side effects, but who wants to fast, right? So my science collaborator went back to the lab and designed a special diet that, taken around the time of chemotherapy, we hope will reduce the side effects because it puts your body into some kind of protective state. When you look at what your normal cells do when you are fasting, they stop dividing, they upregulate antioxidants and things that are going to repair DNA. There's like 1,000 changes that happen. And your cancer cells, they don't care. They are too dysregulated. They just keep doing their abnormal behavior. In fact, we think that maybe this kind of approach, fasting or this fasting type diet, might sensitize the cancer cells to chemotherapy. We have some preliminary data. So we are doing a trial where you get this lovely diet of broth. It's not much, but it's not fasting. At least you can sit down 3 times a day and you have something, some calories, some nourishment. And that's something we're doing whether you're getting a Taxotere up front with your hormone therapy or whether you're getting it after hormone therapy has already failed. And hopefully next time I come to speak we'll have some results to share. So a summary, and then I have a couple extra slides that I wanted to talk about briefly. My take-home messages are that, Taxotere chemotherapy should not be the end of the line. It's really a useful tool, much more powerful than I would have predicted when we use it earlier. And so it's not the thing to be avoided at all costs. It is something that if your doctor were to suggest to you, keep an open mind to it because it really can be quite effective. We can do our best to make it livable, and it's not forever. After chemotherapy, life goes back to normal. You go on to other treatments. It's 6 doses if you're doing it in the upfront way, like the CHAARTED trial. And really that benefit seems to be even greater than what we see when we use it later. And then, of course, my little plug. If you ever want to help contribute to the advancement of science and the advancement of treatment, then think about a clinical trial, because that's how we get our new treatments and our new drugs. So a lot of people, this is kind of just extra, not on the chemo topic for a moment. A lot of people ask about how to use the drugs we have. So should I take Zytiga first or Xtandi? Should I use them back to back? And last year at ASCO in Chicago, I had the privilege of talking about some of the data that were being presented. And some of it speaks to this question. And what I thought was very interesting was this particular waterfall plot, and I'll share it with you. Waterfall plots show how much your cancer changes after treatment. So everyone starts on the 0 line, and if your line goes down, you have less cancer. Either your PSA is going down or spots that we can measure on a scan are shrinking. So it's good to be going down. If you're going up, it means your cancer's growing. And this study was looking at people who took abiraterone, Zytiga, and enzalutamide, Xtandi, in sequence, one after the other. Because what we found, one drug got approved, the other drug got approved, we're using them. Why aren't we getting as good results as we saw in the clinical trial? People were on them 18 months, everyone was responding. One after the other, there seems to be a lower likelihood of response. It doesn't mean it's not worth trying. These guys who took Zytiga first and then Xtandi, all these guys still benefited from both drugs. So when you hear people talking about, one drug won't work after the other, it's not all or nothing. These guys respond to both. These guys didn't respond to either. So our drugs aren't perfect, and we think we are starting to understand the biology behind this, the androgen receptor splice variants, where they don't need testosterone in order to be activated and growing. And then you have some people where the Zytiga worked and Xtandi didn't, or Zytiga didn't work and Xtandi did. So if you try one drug and it doesn't work, it doesn't mean the next one's not going to work. So I think this is important for people to hear, because probably people are talking a lot about their experience going from one drug to the other. We don't really know, and we don't know whether we should be using them together from the start. But there are some doctors that are doing that already. So these are all questions we have, and in the Q&A, if you're interested in this, we can talk more. And then finally, I just want to show you, and maybe this is overwhelming, the changing landscape of prostate cancer therapy. This is really exciting. We went from having two treatments, really, hormone therapy and chemotherapy, to having a whole host of treatments. So we have immune therapy, Sipuleucel T, which is Provenge. We have Zytiga. We got a new chemo drug, Jevtana, cabazitaxel. We got Xtandi. We got radium-223, which is an intravenous radiation that works in bone metastases. So many more choices. And yes, it makes it a little more confusing, but also what it's doing is helping men live better and live longer, and that's fantastic. But we're still in this era where we categorize you so macroscopically. We say, okay, you have metastatic disease. Are you symptomatic, or are you minimally symptomatic or asymptomatic? And that's how we're choosing our treatments, which is really, I hope, not what we'll be doing 10 years from now. We're just starting to get to the point, potentially, where we might say, oh, let's measure in your blood and see, do you have androgen receptor splice variant? Well, then throwing Xtandi and Zytiga at you is not going to help, and let's try something different. And there's one drug that has shown some preliminary data that it can work, even in the presence of that kind of more resistant form of cancer cell. People are also looking at giving things earlier. So this ARN-509 you may have heard about is a new androgen receptor blocker, so it's along the lines of Xtandi. And they're trying to give it right when PSA starts to rise after surgery or radiation. Because like you saw with the CHAARTED trial, giving chemo earlier seemed to have more benefit, so everyone's jumping to earlier settings. So we don't know if that's the right approach, but that seems to be the way people are also working on having a bigger impact, keeping you guys feeling as good as you can for as long as you can. So that's it, and I guess now I'll take questions.
Okay, do me a favor, since we don't have the microphone, folks, if you have a question, let me recognize you, and please stand up so that your voice carries up to Dr. Dorff. Yes, sir, Jim.
Thank you, Doc. Very interesting. I was always confused about why you would use chemotherapy in conjunction with ADT, because when you have ADT, your cells are not dividing. At least now I understand that there are possibly two or more populations of cells, and some of them are still dividing, even though you're under ADT. Do I have that correct?
Yes, that's the picture with the yellow dots and the red dots suggests that. And it's not that we know this for sure. It's a hypothesis as to why we saw those results with using chemo early. Many people have postulated that resistance to hormone therapy develops only when you apply hormone therapy, that it's like an evolutionary selection process. But that may not be true. It may be that de novo, if there's enough cancer around, some of them have become resistant, and that's exactly right. So the hormone therapy is getting rid of the ones that are sensitive to it. The other cells are still dividing and can be knocked out with the Taxotere. It's a paradigm that hasn't worked in breast cancer, and that's where what you were saying kind of comes from, is they gave hormones plus chemo at the same time in breast cancer and got less efficacy. Maybe the estrogen receptor hormone pathway is just working differently in the cancer cell.
Yeah. Well, there are, 27 different kinds of prostate cancer, so there's no question that you're likely to have more than one at one time.
Yeah, that's right.
Anybody else? Yes, sir.
Yeah, a question about the chemotherapy, the Taxotere specifically. You said 6 cycles. Does that mean 6 times you get it?
Yes.
And then also, how often do you go through that 6 times? And after a year, do you do it again? Or?
So the 6 times was the CHAARTED study, and they did it just the 6 times because their question was, should we give it right at the beginning, or should we wait till hormone therapy fails and then use it? When you use it in that setting, there's not a 6-time kind of strict rule. In fact, those 2 studies I showed from 2004 that got Taxotere approved for prostate cancer, they used more like 10 doses.
Okay.
But so I think there's not one right number. Your doctor, there's not one right number if you're using it after hormone therapy has already failed, when you're castrate resistant. When you're using it up front, I would do 6 because that's where the data are. But even so, you know, it's not like you're committed where after 5, if you are super sick, your doctor's not going to push you through to number 6. But in the resistance setting, if that's when you're doing your chemo, your doctor may stop you after 4 or 8. It'll depend whether you're getting side effects, whether they're still seeing continued drop in PSA. So, you know, you might treat till maximal response. You'll see the PSA drop, and when it starts to level off, maybe that's when you stop.
Also on the side effects, you didn't mention like stomach upset and vomiting and also hair loss on Taxotere. Does that occur on?
So the nausea is much less common. There are chemos that cause a lot of nausea. Taxotere does not cause a lot of nausea. So we give a little dose of something before your treatment to prevent nausea. And I stopped writing routine prescriptions for my patients to have something at home because honestly, most of them never filled it. Some patients will get nausea, but it's uncommon. Hair loss is common, unfortunately.
Okay.
Yeah.
Thank you.
Yes.
You mentioned that you tried that drugs are designed, or the file was designed for those that had maximum 30 days of ADT, correct? Does that also apply if the drugs and use of chemo for the guys that had either radical or radiation already, or would that work? Or would you consider that if you still have your prostate?
Yeah, so some of these guys had never had a radical prostatectomy or radiation because unfortunately sometimes when we find prostate cancer it's already metastatic. So it's the same regardless of what you had done to your prostate initially or whether you had anything done. The 30 days, just to be clear, was just a window for enrollment, which is to say that when they're asking the question of early versus late, they wanted to try to not muddy the waters and take someone who's been on hormone therapy 3 or 4 months, right? They tried to get you within that first 30 days so that we could really call it early. Does that mean that if you've had hormone therapy for 60 days and we give you 6 doses of Taxotere, you won't benefit? No, we don't know exactly where that cutoff is, except that the control arm, you know, probably on average got their hormone therapy for 18 to 24 months because that's the, you know, what we quote as the statistic for the average time to resistance to hormone therapy.
Go ahead, Arnie.
Yeah, I have a clarification question first. On the PREVAIL study, this is the one that you talked about, it's a 17-month. But that had seen 2 other drugs, and then you started talking about Taxotere. So is Taxotere part of that 17-month
So that
increase in lifespan?
statistic, the PREVAIL study was enzalutamide,
Right.
Xtandi, or placebo in men who had not yet gotten Taxotere. And the statistic of 17 months is the delay in the time to getting Taxotere.
Okay, so
After the Xtandi or placebo failed, most men went on to get Taxotere.
but it was continuous. So they started off with hormone therapy and enzalutamide and...
Oh no, so this was already for castrate resistance. So these guys got their Lupron and Casodex,
Right.
or just Lupron. And then around 18 to 24 months, whenever they became resistant, that's when they were eligible. And then they were assigned to either Xtandi or placebo without knowing.
Okay. Now, does it work with, you mentioned about bone metastasis, does it work with lymph nodes?
Does which?
The
Xtandi or the
well,
chemo?
the first, the one that, because you said that once they became resistant, then you switched to Taxotere? Is that?
Yeah, so our standard paradigm has been hormone therapy, and when that fails, then Taxotere, although now we have choices. Yeah, the thing about pills or chemo that goes in the IV, unlike radiation, the pills or the IV, they travel everywhere in the body, and so they can affect cancer, whether it's in your lung or your bone or your lymph node, anywhere in your prostate, anywhere, right? So a lot of times people ask me, well, why don't you use radiation? So radiation only works where you point it. except for radium-223, which is a different kind of a treatment. But yeah, the idea is any cell that's rapidly dividing or any cell that's using androgen receptor, in the case of Xtandi, is going to be sensitive to it.
What again, when you first started off the presentation, it looked like you were talking about the PREVAIL study. It included people who were just starting on.
So I'm sorry if that was confusing.
Okay, Chris.
The focus of my talk was chemo, because that's something that we talked about being of interest. PREVAIL is something different. Okay. PREVAIL was Xtandi after failure of Lupron-Calcidex type therapy, and it got the drug approved, but it was never tested right up front.
Okay. So Taxotere is the one that you're talking about, where you started up front.
That's the 6 doses up front. That's the CHAARTED study.
Right, and that's the one that showed what added how many months to?
For high volume disease, it was, what was it, 17 months?
17 months.
Yeah.
Okay, so, and that's available right now? Is that something that?
Yeah, so Taxotere's been around. It's been approved for prostate cancer since 2004. And essentially what happened here was we were sort of teaching an old dog new tricks. We tried to use a drug in a different way, and it seems to potentially work better when we use it this way than how we've been using it. But it's totally available, FDA approved, should be covered by your insurance.
Okay. So personally, I just started hormone therapy today, and I don't have any bone disease as far as I took a C11 acetate test and also a better bone scan. And
Speak up, Arnie, people in the back.
I'm sorry, can you hear me? Anyway, so I would be a candidate for using Taxotere along with that therapy.
I mean, it's something you'll have to talk to your doctor about for the specifics about whether he thinks it's a good idea for you. But theoretically, the idea is someone who just started hormone therapy, trying to fit you into, are you high volume or low volume is where you need to talk with your individual doctor to try to get a sense of the magnitude of the likely benefit for you.
All right, thanks.
I have a question. You use the terminology high volume, low volume. Is that a quantifiable number that determines which is which?
So the way they defined it, there's probably not just one way to define it, but the study defined it as 4 or more bone mets, one of which is outside your axial skeleton, which is your spine and your pelvic bones. So for instance, 5 bone mets with one being in your rib or one being in your arm, that counts as high volume. If you have 2 bone mets that are both in your spine, you're low volume.
What if you don't have any?
So high volume probably also includes things like lung metastases. Lymph node, I don't know where that would fit in. I'd have to look and see how they stratified those.
Okay, my turn. Can I ask a question?
Sure.
On some of your side effects for chemotherapy up there, you listed neuropathy, and then it said medications.
Yeah.
Do you have any comment on what medications could be used for neuropathy?
So the one that has the most published support for it is duloxetine. So that's for people who are really having kind of irritating, painful, pins and needles kind of neuropathy. It can help. But really with time, most people get relief from the neuropathy. Some of it is dose dependent, so the more doses you get, the bigger the possibility that the neuropathy won't go away, and that's one of the things your doctor does when they check you, is ask you about numbness, tingling, and they might adjust your dose of your Taxotere, or they might say, we ought to stop because I don't want to see you with long-term neuropathy. I have a patient who just finished, I want to say 8 cycles of Taxotere, probably 5 or 6 months ago, and he developed pretty bad neuropathy where it was keeping him up at night with the pins and needles kind of sensation, and we gave him the medicine and it helped a lot, and now 5 or 6 months later we're kind of taking him off the medicine and he's finding that his feet are feeling better. So hopefully most of the time it's reversible, but care has to be taken.
What was the name of that medicine again?
Duloxetine. I forget the brand name, sorry.
Okay. I normally discourage personal talk here, but I'm going to ask one question. It's personal. I have some beginning neuropathy. In your opinion, it's my toes and balls of my feet, and it seems to be getting slightly worse as we go along. In that opinion, would that prevent me from taking the chemo like is in the CHAARTED trial, if I get all the other parameters?
Yeah, so having neuropathy already, like from diabetes or from some other reason, could potentially exclude you because we always are trying to balance benefits against harms, and you are more likely than to get to a higher level. So we grade side effects, what we call toxicities, 1, 2, 3, 4. So if you're starting with 0, no neuropathy, and you get to grade 1, there's a less significant impairment of your lifestyle than if you start with 1 and we push you to 2. So on trials, they will usually exclude anyone who has significant neuropathy from the get-go. But, you know, again, this is the kind of fine detail point where you'd need to work with your doctor.
I just saved a couple $100 for a doctor's appointment. Okay, any other questions? Dr. Dorff, we always appreciate you coming here. You're one of our favorite speakers here. We can't afford to pay you, but we can save you some time, and time is money in a doctor's life, right?
Yes.
So here is a cup of coffee. You can put your coffee and set it in your coffee holder in your car so that you can drink your coffee on the way to work instead of doing it. Thank you very much, Dr. Dorff.